Acute Care Nurse Assistant, Module 13, Neurological Care. Statement of Purpose. The purpose of this module is to prepare the nursing assistant to perform skills necessary to safely care for the neurological patient. The student will learn to recognize and report abnormal signs and symptoms to the licensed nurse. Terminology. Performance standards. Upon completion of 4 hours of class, plus assignments, and 4 hours of clinical experience, the learner will be able to define basic terminology, describe basic anatomy and physiology of the nervous system, list common neurological disorders and conditions of the nervous system, explain common tests used to diagnose neurological disorders, discuss the care of the patient with neurological disorders. Describe abnormal signs, symptoms, or behaviors related to neurological disorders. Recognize signs and symptoms of swallowing disorders and necessary precautions to follow. Describe the role of the nurse assistant when caring for a patient experiencing a seizure. And describe equipment commonly used in caring for patients with neurosurgery, head trauma, and spinal cord injuries. References. Content Outline Theory sections. Section 1 is Basic Terminology and Clinical Application. Section 2, the Basic Anatomy and Physiology of the Nervous System, the Brain, Spinal Cord, Nerves, and Sensory Organs. Section 3, Common Neurological Disorders and Conditions of the Nervous System. A. Head injuries. Scalp, skull, brain, concussion, contusion, skull fracture, and cerebral hematoma. B. CVA. Left side paralysis, right side paralysis. C. Transient ischemic attack, TIA, temporary period of diminished blood flow to the brain, may last 2 to 15 minutes or up to 24 hours. Symptoms similar to stroke, but temporary and reversible. Increased risk of stroke. D. Brain tumors. E. Altered states of consciousness, coma, dementia, delirium, and Alzheimer's disease. F. Seizures and epilepsy, grand mal, or generalized, petit mal or partial, and status epilepticus. G. Spinal cord injuries, quadriplegia, and paraplegia. H. Degenerative diseases, myasthenia gravis, multiple sclerosis, Guillain-Barré syndrome, and Parkinson's disease. Section 4. Common tests used to diagnose neurological disorders. Computed tomography, or CT. Magnetic resonance imagery, MRI. Electroencephalogram, EEG. And lumbar puncture, LP. The care of the patient with neurological disorders. Patients with neurological disorders are at risk for changes in body function and long-term disabilities. Signs and symptoms that must be observed carefully in the neurological patient. Vital signs. Changes in vital signs may be a late sign in patients who are having pressure increasing in and around the brain. Observe the following changes. Pulse and respiratory rate slow. Blood pressure and temperature rise. Look for hypertension, bradycardia, and respiratory irregularity, such as Shane-Stokes or Kussmaul breathing are the respiratory irregulars frequently seen. Change in level of responsiveness or level of consciousness. Lethargy, slowing of speech in response to verbal suggestions. Subtle changes, restlessness, headache, personality change, speech change, changes in breathing pattern, purposeless movement, and mental cloudiness. Positioning restrictions. Head of bed, HOB. Keep head of bed slightly elevated or as ordered. The rationale: if there is any inflammation or swelling in the brain, the pressure inside the skull and brain is increased as the patient lies flat. Elevating the head of bed slightly helps to increase venous drainage and prevent additional pressure being placed on the structures inside the skull. Body alignment. Keep head in alignment with the body. Avoid neck flexion and extreme hip flexion. Rationale: these positions can impair blood flow and increase intracranial pressure. Reality orientation. Skin care. ADLs. Assist with ADLs as appropriate, such as a comatose patient will need total care. Mobility or movement. Provide range of motion. Log roll the spinal surgery patient. Support dependent extremities. Communication. Aphasia. There is fluent, non-fluent, and global. Considerations. Ask yes or no questions. Avoid treating or speaking like a child. Do not correct speech. Use gestures and/or charts. Be sensitive to behavior changes or feelings, such as being angry, sad, embarrassed, or frustrated. For seizure precautions, see Section 8. Bowels and bladder. Incontinence and urine retention. Restrictions of noise and light. Quiet environment. No bright lights. Airway risks. Maintain clear airway. Oral suctioning, positioning, feeding and swallowing precautions. Section 6. Abnormal signs, symptoms, or behaviors related to neurological disorders. Abnormal vital signs. Neurological signs regarding impaired mental status, such as the ability to follow commands, changes in behavior or mood, decreased level of consciousness, such as being unresponsive, disoriented to time, place, person, or purpose, the inability to communicate, to perform ADLs, move extremities, see, hear, or swallow, uncontrolled body movements, decreased reaction to pain or stimuli, decreased or loss of sensation or feeling, dizziness, and vomiting. Section 7. Signs and symptoms of swallowing disorders and necessary precautions to follow. Signs and symptoms of swallowing disorders: dysphagia, coughing when trying to eat, choking on foods or fluids, drooling, spilling food from mouth, pocketing food in cheeks when eating, wet or moist-sounding voice during or after eating, increased congestion in the chest, multiple swallows per bite, extra effort or difficulty chewing or swallowing, fatigue or shortness of breath when eating, elevated temperature 30 minutes to an hour after eating, and frequent pneumonia. Precautions. Create a peaceful, low-pressure eating environment. Approach patient calmly. Limit visitors during mealtime. Correctly position patient sitting upright in firm chair. Place towel under chin. Have patient concentrate on swallowing. Do not rush the patient. Check that foods are not too hot or cold. Have patient take small bites. Caution with liquids. May need thickener. Have patient swallow twice after each bite. Keep patient's head forward during swallowing and chin midline. Alternate solids and liquids. Begin with liquids if patient's mouth is very dry. Report any difficulty with feeding and the amount the patient ate. Signs and symptoms of a choking emergency. Partial, wheezing or gurgling, difficulty breathing or coughing. Complete obstruction, clutching of throat, inability to speak. Call for help and perform the Heimlich maneuver. Resource personnel are speech therapists, occupational therapists, and the licensed nurse. Section 8. The role of the nurse assistant when caring for a patient experiencing a seizure. Identify activity that precedes a seizure. Many patients will have an aura that precedes seizures and can notify nursing personnel. Aura is a particular sensation that immediately precedes the symptom of a seizure. Some examples are a peculiar taste or smell, ringing in the ears, dizziness, visual disturbances, or numbness in a body part. Prevent injury to the patient. Stay with the patient, never leave them. Call for help immediately. According to facility policy, know your emergency numbers. Assist patient in lying down. If in a chair, gently lower the patient to the floor. Clear away equipment or objects that may cause injury. Never attempt to restrain the patient who is having a seizure. Do not attempt to put anything in the patient's mouth, and support their head with a pillow to prevent the patient's head from striking the hard surface of the floor. Cover side rails with pads if the patient is in a bed. Observe seizure activity carefully and give detailed reports to a licensed nurse, including time seizure began and ended, what part of the body was involved, and the type of spasm activity, such as mild tremors, severe shaking, etc. The patient may be incontinent during a seizure. Be prepared to give incontinent care after the seizure. Monitor the patient after the seizure, as there's usually a period of confusion, lethargy, and possibly apnea. Maintain airway by the head tilt, chin lift method. Loosen patient's clothing around neck and chest. Turn patient's head to the side to drain secretions. Monitor patient's respiratory rate and depth. Have suction equipment at the bedside for licensed personnel. After seizure is finished, position the patient on his or her side. Stages of a seizure. Aura, a peculiar sensation immediately preceding the onset of a seizure that may take the form of abdominal, visual, or hearing disturbances. Prodroma, early clinical signs such as malaise, which is a sick feeling, headache, sense of depression. They may occur hours or days before the onset of a seizure. Tonic phase, a state of muscle in which there is excessive muscle tone, a stiffening of arms and legs. Clonic phase, a state of alternating contraction and relaxation of muscles. Postictal state, the time period immediately following the sensation of seizure activity, often a time of confusion and lethargy. Section 9. Equipment commonly used in caring for patients with neurosurgery, head trauma, and spinal cord injuries. Specialty beds, the Stryker frame, used for cervical traction and spinal fusion and laminectomy, used to maintain immobilization and provide for turning. Only used in specialty units and require special training to use, and it is not used often anymore. Circolectric bed, turns vertically to help patient become accustomed to upright position, allows for immobilization and turning, used only in specialty units and rehabilitation facilities, requires special training to use. Low air loss beds, such as the CNA, Flexicare, Mediscus, Biodyne, Therapulse, and others. Many air-filled cushions, each may be filled to a different firmness. They result in pressure reduction, temperature control. May be drying on the patient's skin, so monitor the skin condition and report to an RN. Can be deflated for CPR. Requires special linen. Some rotate from side to side and pulsate to stimulate circulation and mobile respiratory secretions. Air fluidized beds, such as the Clinitron, Skytron, Fluid Air, or the SMI 5000. Air forced through tiny ceramic beads, allows no pressure on the body surfaces. It is not used for spinal cord injuries. It is too soft for spinal alignment. Monitor patient for dehydration because of the drying effect of airflow. Uses special linen. In-service needed for techniques to position and transfer patient. Patient does not turn as much and may have buildup of respiratory secretions. The rotation bed, such as the Keen Mobility, Rotorest, Tilt and Turn Paragon, moves patient from side to side about every 7 minutes. Traction may be attached. Patient may experience motion sickness. Mobilizes respiratory secretions, stimulates gastrointestinal activity, stimulates circulation, and prevents excessive pressure on skin. Requires special training needed to use the bed. Skull tongs, surgically implanted into the skull bones. With break-in skin barrier, infection is possible. Traction applied to immobilize the cervical spine. Head of bed may be raised for countertraction. Pin care precautions. Special training is required for pin care. May be part of a nurse assistant duties in some facilities. Keep pin sites dry when bathing patient. Slight oozing is possible at sites. Wear gloves when bathing patient. Observe for signs of infection or drainage at the site each time care is given, and every 2 hours when turning. Observe for loose pins and report to the RN immediately. Look for signs of infection, including redness, heat, drainage, odor, pain, or fever. These signs and symptoms should be reported immediately to the licensed nurse. Halo brace, external immobilization device, a vest worn by the patient, used after spine stabilized by surgery or after short time of healing. It is usually worn for 8 to 12 weeks. Physical and occupational therapy can be initiated early to aid recovery. Never lift or reposition a patient by grasping the metal struts on the halo brace. Lined with sheepskin that must be cleaned. Vest removed and sheepskin changed by specialty trained RN. Inspect skin under brace with sheepskin frequently. With special training, may use blow dryer set on low to dry skin under brace. Keep skin dry under brace and the sheepskin. Intracranial drain or pressure monitor. Used to monitor pressure in the brain. Only in ICU or specialty units. Caution must be taken not to dislodge the catheter when giving care. Head of bed is usually elevated. Never change the position of the bed unless directed to do so by the RN. Dressing over the site must be kept dry. Be careful when bathing the patient. Notify the nurse of any loose connections. Fluid balance is important, as fluid retention can increase intracranial pressure. Record accurate input and output and urine output. Observe the patient for signs and symptoms of meningitis, fever, chills, neck rigidity, increasing or persistent headache. Observe patient for any changes in mentation, such as increased lethargy, sleepiness, confusion, or change in respiratory patterns. Nervous System Worksheet. Match the definitions on the right to the blank on the left. Nervous System Worksheet Answer Key. Characteristics of left-sided paralysis. Description: left-sided paralysis is usually the result of a right brain injury. The most visible sign of damage is paralysis or weakness on the left side of the body. Common characteristics of people with left-sided paralysis are as follows: facial droop, pocket food because of the inability to feel the left side of the face, seldom have speech problems, loss of the ability to judge distance, size, position, rate of movement, form and relation of parts as wholes, difficulty steering wheelchair, may confuse the inside and outside of their clothes, or left from right, or misperceive how far away an object is. Difficulty in reading a newspaper or adding a column of figures because they lose their place on the paper. Severe balance problems, problem with sitting or standing, may lean to the left, may feel like they are being pushed over when assisted to sit or stand. May not recognize their own arm or leg as parts of their own body. They may perceive someone else is in bed with them. They may ignore anyone who is speaking to them from the impaired side. Left-sided neglect or denial. No left-sided visual field. May eat only what is on one side of the plate. Becomes easily lost or confused when traveling. They may have no idea where they have been in an unfamiliar corridor. They have seen one side of the corridor going and on one side coming. To them, it may seem as if they've traveled two different corridors. Poor motor planning skills and problem-solving abilities. Poor judgment about their level of skill and a tendency to overestimate their abilities. Impulsiveness and rapid movement as compared with slow and cautious people with right-sided paralysis. Difficulty understanding the visual cues they receive from the environment. Problems with short attention spans. New learning and generalization of problems. Interventions. Modify the environment to compensate for deficits. Furniture and personal items may have to be moved so that they are on the unaffected side of the bed or wheelchair. The person's place at the dining table should be arranged so that he or she receives food items from the unimpaired side. Guests should be invited to sit on the unimpaired side. Beds should be placed so the unimpaired side of the individuals are such that they can respond to activities going on in the room. Reminders of landmarks when traveling. Point out landmarks on both sides of the corridor when traveling to a destination, and give frequent reminders of the destination. Do not expect the person to find their way back alone. Provide encouragement and support through active listening and encourage verbalization. Also, be aware of any potential safety issues. Characteristics of right-sided paralysis. Description: right-sided paralysis is usually the result of an injury to the left side of the brain. People with right-sided paralysis are likely to have difficulties with speech and language, aphasia. They particularly have difficulty speaking, non-fluent or expressive aphasia. Common characteristics: preference for more habitual ways of doing things, a tendency to be slow, cautious, and organized when approaching unfamiliar problems, the ability to speak and understand, but not to read, write, or do arithmetic, short retention spans and limited attention spans, good judgment about the level of skill, marked difficulty with new as opposed to old learning, a tendency to pocket food in one cheek, and good motor planning skills and problem-solving skills. Sitting and standing balance problems. The inability to generalize information in order to solve a problem. The loss of the right visual field. Memory difficulties associated with language. The impairment of swallowing, dysphagia, or the gag reflex. Good visual spatial skills not impaired by vision field cut. An example of a neurological flow sheet. Reporting neurological signs. Equipment used: a pen light. Directions: Works in pairs for this activity. One person acts as the subject, the other as an examiner throughout the activity. The roles may be reversed. Record the information on a piece of paper as it is observed. Use 3 columns. Label the columns right, left, and comments. Label arrows, responsiveness, orientation, facial, hands, and feet. Observe the subject to determine the level of responsiveness. The level of responsiveness may be described in one of the following terms. Alert, aware of the surroundings and environmental stimuli, responds to verbal stimulus such as talking. Lethargic, may be aware of environmental stimuli with assistance, responds to loud verbal stimuli or touch. Stuporous, does not respond to environmental stimuli, may be roused with return to sleepwalk state quickly, responds to touch and pain stimuli. Comatose, does not respond to any stimuli. Determine the orientation of a subject by asking questions that assess awareness of the person, place, and time. Questions should require more than a yes or no answer to determine if the answer is appropriate. For example, tell me your name, please. Asks for orientation of a person. If a visitor is present, ask the patient his or her name. What day of the week is it? Asks for orientation to time. This question may be difficult for someone who has been hospitalized for a while. Knowing the year or the name of the current president would be acceptable in this and some other circumstances. Tell me the name of this facility. Asks for orientation to place. Knowing the city or similar information would be acceptable in these and some other situations. Normal orientation is oriented times 3 to all 3 areas of inquiry. If the subject cannot answer or gives incorrect responses, the correct information should be given to the subject to prevent anxiety and to help him or her to become oriented. Facial. Instruct the subject to stick out their tongue as far as possible. The tongue should extend in a symmetrical manner on both sides. Hands. Instruct the subject to grip and squeeze the index and middle finger of both of the examiner's hands as hard as possible until asked to stop. The grips of the subject should be equal and strong. Feet. Subject should be lying down or sitting with the legs extended. The examiner places one arm across the soles of the subject's feet and instructs the subject to push as hard as possible with both feet. The push response of the subject's feet should be equal and strong. Equipment for neurological patients. Equipment: specialty beds if available, cervical collar, halo vest, skull tongs. Criteria: demonstrates correct positioning for neck stability, demonstrates how to log roll a patient, demonstrates transfer techniques and positioning for the paraplegic or quadriplegic and stroke patients, role plays how to manage a patient having a seizure.